Hello, I'm Dr. Mark Rothenberg here at Cincinnati Children's Hospital. I'm a professor of pediatrics, the director of the Division of Allergy, and I'm most proud to also be the director of the Rothenberg Cured Lab. I want to take this opportunity to thank Ellen Kodroff and all of her members of the Cured Foundation that are supporting the research that we've been doing in my lab, designed to understand the causes of eosinophil-associated diseases, especially eosinophil GI diseases, and the best treatment and hopefully cure in the near future for these diseases. Ellen asked me a series of questions about COVID. These are very timely questions, and I thought I would take this opportunity to answer them in an informal manner. And I know this is important to so many of you, so I'm doing this rather quickly and briefly. If you have any further questions, please do not hesitate to ask Ellen, and she'll get the questions to me. The first question: is the Delta variant more concerning than the first round of COVID for an aged patient, especially since it's making children ill? Also, what about hypereosinophilic syndromes or eosinophilic asthma? And the answer to this question is that the Delta variant is more concerning in general, but it is not more concerning for eosinophilic patients, nor eosinophilic asthma patients or hypereosinophilic syndrome patients. In general, what we've seen is that patients with severe eosinophil GI diseases are not more susceptible to COVID. In fact, some of the early data that we and others have generated has indicated that we may even see a little bit of protection. That being said, now there are some patients that may be considered immunosuppressed, particularly those who might be on systemic immunosuppression therapy, particularly those with hypereosinophilic syndromes, for example. And those patients would fall into the category of immunocompromised patients, and they might be more susceptible. This is not the typical eosinophil GI patient, however. The Delta variant is more contagious. It is inconclusive at this point in time if it's actually more dangerous in terms of how it affects the body. For those that are vaccinated, should they ask their physician about the booster shot? You can certainly ask your physician. At the current time in the United States, the booster shot is restricted to patients that have a bona fide immunodeficiency. EGID is not considered a bona fide immunodeficiency, and it would be difficult to get the third dose or the booster vaccine at the present time. I do suspect in the near future that the third dose will become more readily available, more readily approved by the FDA, and I myself are looking forward to getting the third dose, the booster, as soon as I'm eligible for it. How do eosinophils respond to the COVID-19 infection or the vaccine? In general, eosinophils are not part of the primary immune response against COVID nor the vaccine. We do know that the level of eosinophils is a positive prognostic factor for outcomes in COVID. What that means is that if your eosinophil levels are higher, then you actually do a little bit better with COVID. That doesn't mean a hypereosinophilic patient is going to do better. What that means is when patients present and they're very acutely ill from COVID and they're likely to get hospitalized, the level of eosinophils in the blood is known to be a prognostic factor. And if the eosinophil levels in the blood are particularly low, that has been shown early on in COVID that leads to poorer outcomes. Now, we typically see that in any viral severe infection. Eosinophils are often depleted in the blood. This is true also in cases of bacterial infections, and the eosinophil rise occurs soon after the infection is treated. This is probably not a specific phenomenon for COVID, and it's really not of concern for patients with eosinophil GI diseases. Should a patient get one Pfizer, J&J, or Moderna, or doesn't it matter? The answer to that question is I would take whatever you can get, and I would recommend vaccination for all, and take whichever vaccine is readily available to you. The vaccines aren't necessarily interchangeable, although they have been studied already and shown not to have increased adverse events when they are used in conjunction with each other. Currently, the booster dose, it's recommended to take the same vaccine that you originally got. However, if it's not available to you, it's okay to take another vaccine. The Moderna and Pfizer vaccines are basically comparable. They're both mRNA vaccines. The Johnson & Johnson and AstraZeneca vaccines are somewhat different. They're made with a different platform. It turns out that they seem to be a little bit less effective than the mRNA vaccines. But I still would recommend taking them if that's what you can get rather than mRNA vaccines. Does EGID, HES, asthma, and mast cell patients, should they be more concerned about getting the vaccine? Also, patients with many allergies seem to be overly concerned about taking the vaccine. What are your thoughts about this? My thoughts are that everyone should get the vaccine. These vaccines are very strongly beneficial. The risk is low compared to the reward, and that's why there's a pretty strong recommendation to get the vaccine, whether you have allergies or whether you have a chronic disease, whether you have EGID or not. Now, there are very special circumstances when one might have some caution about taking the vaccine, such as individuals that have had prior anaphylaxis to vaccines, and those individuals with a rare allergy to polyethylene glycol, or PEG, which is a constituent of the mRNA vaccine. Certainly, if you've had a rare anaphylactic allergic reaction to the first dose of a vaccine, then one should not take the second dose. If you have any questions about these very rare circumstances, please bring them up with your healthcare provider. Bottom line is that EGID is not a contraindication to the vaccine. Food allergy is not a contraindication to the COVID vaccine either. Should a patient be concerned about a cytokine storm? Well, I think you're better off being more concerned about a thunderstorm than a cytokine storm. A cytokine storm can occur. It's usually associated with COVID, not the vaccine. It's a very rare occurrence. It's more common in pediatrics than in adults, although cytokine storms, depending upon how they're used broadly, are associated with the COVID pneumonia. In some patients, they have a so-called cytokine storm. Cytokine storms basically is a terminology used for a hyperactive immune response. It's one thing that somebody should not be concerned about, but it can happen to you, like many things can happen in terms of the body having an acute problem. Cytokine storms are treatable. It doesn't mean you're necessarily going to perish. There are specific medications now that have been studied and shown to be beneficial for cytokine storms. I wish you stay free of the cytokine storm. Wear your raincoat. I'm serious now. It's a very rare occurrence, and it's one of the last things I would be concerned about in terms of the vaccine, and it is associated with the very rare, severe outcomes of COVID. But it's one that typically does not happen. And interestingly, in terms of the fourth wave, we're seeing less cytokine storms than we did with the earlier waves of COVID. So I hope that these questions have been answered. I'm sure there are others, and I'll be available to answer those as well. I want to take this opportunity to once again thank the Cured Foundation for supporting research that we're doing on eosinophil-associated diseases, and thank in particular Ellen Kodruff and Fred Kodruff and all of your close supporters, particularly the Board of Cured, for all that you're doing to advance eosinophil-associated research here at Cincinnati Children's and many other places and around the world. And thank you, Ellen, for being a patient advocate for so many people at this important time.